ค่ะก็ขอสวัสดีท่านแขกผู้มีเกียรติทุกท่านนะคะที่มาเข้าฟังการบรรยายในวันนี้นะคะวันนี้ทางทีมงานของเราก็ดีใจเป็นอย่างยิ่งเลยที่ได้มีการจัดพูดในเรื่องของ Urban Health ในครั้งที่3นี้นะคะซึ่งในครั้งที่1ครั้งที่2ที่เราได้จัดกันไปก็ได้รับความร่วมมือจากทุกท่านเป็นอย่างดีนะคะแล้วก็ได้รับการประเมินผลผ่านตัวชี้วัดกันทุกคนเลยนะคะครั้งนี้ก็เป็นครั้งที่3แล้วก็เป็นเกียรติกับทางโรงพยาบาลคณะแพทย์มหาวิทยาลัยของเรามากเลยที่ได้รับเกียรติจากวิทยากรต่างประเทศนะคะที่จะมาพูดในวันนี้ค่ะในลำดับต่อไปขอเรียนเชิญท่านคณบดีผู้ช่วยศาสตราจารย์จากกาวุฒิมณีฤทธิ์ค่ะขึ้นฟังการกล่าวรายงานค่ะค่ะค่ะและขอเรียนเชิญท่านรองคณบดีอาจารย์วิโรจน์ค่ะขึ้นกล่าวรายงานค่ะ
Dean of Faculty of Medicine, Washira Hospital, the executives of Faculty Medicine, Washira Hospital, and all participants. As the chairman of the project committee, I feel really pleased and honored in having the presence of Assistant Professor Jakawut Manirit, Dean of the Faculty of Medicine, Washira Hospital, to preside over the opening ceremony of the third Urban Health Knowledge Development Project for the faculty's personnel today. In the fiscal year 2022, the Faculty of Medicine, Washira Hospital, has implemented the Urban Health Knowledge Development Project for academic and professional support staff. The project is comprised of 3 consecutive times of urban health academic lecture, which have been conducted through in-personal and online platform. The first time was organized on 26 November 2021. The second time was on 25th January 2022, and today's lecture will be on the third time. The objectives are, first, to provide knowledge for the faculty staff to understand urban health issues. Second, to promote urban health to be core competency of academic staff and professional support staff. Third, to improve concept and skill of the faculty personnel in managing problem and working with multidisciplinary team. Fourth, to transfer the knowledge on urban health to all involved parties in order to achieve the organization mission to be leader in the urban science. In this connection, on behalf of the project working committee, I would like to convey our sincere appreciation to lecturers and all involved people to their kind contribution and cooperating given to this project. May I now invite Assistant Professor Jakawut Manirit, Dean of Faculty Medicine, Washira Hospital, to give a speech on the opening ceremony of the third Urban Health Knowledge Development Project. Thank you.
Thank you, Dr. Virod. Deputy Deans and Assistant Deans of the Faculty of Medicine, Washira Hospital, Professor Dr. Salmaan A. Keshavjee, participants and project working group. It is my great pleasure and honor to preside over the opening ceremony of Urban Health Knowledge Development Project 2022, with aims to broaden profound understanding on urban health for the faculties, personnel, both academic and professional support staff. The project had already been organized successfully for a couple times. Today, academic lecture is the third time of this project, which I believe that it will be a significant lecture because we have invited distinguished guest speaker from abroad to share his expertise with us. Thus, I would like to take this opportunity to welcome Dr. Salmaan A. Keshavjee, Professor of Global Health and Social Medicine in the field of Medical Anthropology of Harvard Medical School, who will give a lecture on the topic Urban Health and Zero TB Initiative. I do hope that the knowledge receiving from outstanding international experts today will be beneficial to all participants, that they can utilize it to improve their concepts and skills to work with multidisciplinary team, as well as disseminate knowledge to other involved parties for better understanding on urban health issues in order to help driving our university mission to achieve our goal of being the leader in urban sciences. May I now declare this academic event open and invite Professor Salmaan A. Keshavjee to deliver a lecture. Thank you.
อันนี้เลย
Well,
First of all, I would like to introduce you Dr. Salmaan.
Professor Salmaan Keshavjee is a professor of global health and social medicine at Harvard Medical School and the director of Harvard Medical School's Center for Global Health Delivery. He is also a physician in the Division of Global Health Equity at Boston's Brigham and Women's Hospital, where he is associate professor of medicine.
He is a leading expert in tuberculosis treatment and the anthropology of health policy. He is the author of Blind Spot: How Neoliberalism Infiltrated Global Health. He has worked extensively with Boston-based nonprofit partner in health on the treatment of multi-drug resistant tuberculosis. Over the last 20 years, Dr. Salmaan has conducted clinical and implementation research on MDR-TB in Russia, both in the private and civil sector. He was Deputy Director for the Partner in Health programs in Lesotho, launching one of the first community-based treatment programs for multi-drug resistant tuberculosis co-infection with HIV in sub-Saharan Africa. Most recently, he has been working with Advanced Access and Delivery, a non-governmental organization for which he is co-founder and clinical advisor for projects in India and South Africa. His research has resulted in a number of clinical and policy manuscripts on TB and MDR-TB, which have had significant clinical and policy impact.
Professor Salmaan is the chair of Steering Committee for Zero TB Initiative, a global coalition of implementers, policymakers, and activists working to create islands of tuberculosis elimination in a number of countries worldwide. He was the chair of the World Health Organization Stop TB Partnership, Green Light Committee for Multi-Drug Resistant TB from 2007 to 2010. He has been involved in a number of global guidelines for tuberculosis treatment, including the World Health Organization and the American Thoracic Society. During the COVID-19 epidemic, he has been involved with the work of START Coalition, committed to using layer technologies to keep public space safe from airborne disease transmission.
Let us welcome Dr. Salmaan.
Thank you so much to the Dean and the Vice Dean, and thank you so much to dear colleagues for the invitation to speak to you here today at Vajira Hospital. It's a great honor to be here, and it's a great honor to be back in Thailand. I am going to try and figure out how to bring up my talk, though. Let's see. Here it is. Okay. So today I wanted, this is an urban health department, and you are dealing with one of the most important issues that's facing the world today, and that is how to deliver healthcare in urban communities and improve the well-being of people's lives and have an impact, on all of our societies. And, when you start to think about the challenges that we're facing, today I'm going to talk to you about tuberculosis, but in general, it could be anything. I could be talking to you about high cholesterol or high blood pressure. These are conditions that they have considerable risk for bad outcomes. They have considerable risk for premature death. But if you don't know you have it, you don't know that you need care, and you don't know that you have it if nobody is testing you for it. And so, basically, when we start to think about all of these problems that are facing the population of the world, but certainly the population of large urban centers, we are realizing that we are facing a very big healthcare delivery gap. And in most of the world, healthcare is organized around hospitals. But as we know, people don't live in hospitals, thankfully, and you have to be very sick nowadays to end up in a hospital. Hospitals are critical for so many things, but they're not enough, right? The majority of care happens in the communities where patients live, and where they live and where they work. And so when you start to think about it, to ensure that people who need care get care, we have to be thinking beyond the hospital to the last mile of care delivery or the last kilometer of care delivery. And in fact, if we want to be accurate about it, it's the last centimeter of care delivery, right, to the patient. And when we're unable to fill this health delivery gap, we face a problem, because if we can't bridge some of these problems, we're going to end up with some very frightening health emergencies. We have all just come through COVID, right? And we've seen that here's a disease spread in the community that has a fatality rate of somewhere between 0.5 and 1.5%. Visualize another disease that has a fatality rate of 80% if you don't get treatment, that is passed in the air. You guys know what disease I'm talking about, right? That's tuberculosis. That if you don't get diagnosed with treatment and you don't get care, roughly 80% of the people will get full-blown disease and die. And so when you start to think about it, the same systems that we needed to screen people for COVID, you need to screen for TB, you need to screen for high blood pressure, you need to screen for diabetes, etc. And so when you start to think about it, it doesn't require a lot for us to say, well, what do we need? What do we need in order to be able to stop a disease like TB or stop diseases like diabetes and high blood pressure? You need to be able to find people who are sick and find them in the community, and you need to be able to give them the treatment. And so we have to create systems when we're thinking about urban health that can actually do this. So, coronavirus was, of course, very scary for all of us, but coronavirus was like an X-ray. It showed us all the weaknesses in our health system. It showed us where all the breaks were. And it showed us that we were not able to really diagnose and treat people in communities. And of course, 550 million people so far have had coronavirus, and there's been 6 million deaths. And that seems scary. But I'll tell you what's even scarier. Around the corner, by 2040, it's estimated that 700 million people in the world will have diabetes. So that's frightening, right? That's 700 million people that will have, that have a risk of going blind, that may need kidney replacement therapy, high risk of pneumonia, high risk of amputation, etc. And so when you start to think about it, we need to be thinking about urban health and urban healthcare delivery and systems very early on. So the reason I'm going to talk to you about TB is because TB is the disease that allows us to really think about how do you deliver care in the community? How do you diagnose a disease that people don't know that they have? How do you diagnose a disease that isn't just about the individual, but it's about families and communities, because it's a social disease? So it's not just one person in a household that has it. Sometimes it's more people in a household that have it. And so the disease that I think allows us to really think about this is tuberculosis. So I'm going to spend a little bit of time talking about that today and then come back to really thinking about urban health. So all of you are health professionals. You know that TB is caused by Mycobacterium tuberculosis. It's it's a bacterial disease. It's passed from person to person in the air. 10 million people become sick with it every year, and 4,000 people die every day. That's three people every minute die from TB. Now, unlike COVID, TB is treatable, and it's been treatable since 1948. So there's absolutely no reason that it should be the biggest infectious killer of adults. If we didn't have COVID today, TB would be the biggest infectious killer of adults. 1 million children get TB every year, and it's not clear how many of them die, but many do die. So, and it's the biggest killer of people with HIV. So there's no reason that it should be this way, but it is this way. And the interesting thing is, we know that all of this is occurring in low and middle income countries, because in richer countries, TB is actually very rare and only affects vulnerable populations. And when you start to look at it, the TB is both a marker of gaps in the health system, because it tells us that we're not able to get to the community to screen and treat people. And it's also a marker of vulnerability in the social system, because it affects people who are poor, people who have poor housing, people who have poor nutrition, people who are living in overcrowded conditions or spend extended periods in overcrowded conditions. And if you look globally, there has been a lot of effort to control TB over the last 50 years. And despite all the efforts that we've seen outside of rich countries, rates of tuberculosis only go down about 1.5% to 2% a year. So that's very, very little. And basically, it's not enough to stop the growth of TB in affected communities. So, but I told you that in rich countries, it doesn't exist. So this should be a clue for us to ask the question, what is going on in those places or what went on, because in many of these places, because TB rates are low, they've dismantled their healthcare delivery system. But what was done in those places to ensure that TB rates would go down? What did they do to screen people and treat people in communities so that you could bring down a disease like tuberculosis, which is airborne? And what can we learn from that about urban healthcare? Now, if you look at rates of TB in the world, 60% of cases occur in 6 countries: China, India, Indonesia, Nigeria, Pakistan, South Africa. And then there's a group of countries that have very, very high rates of TB, including Thailand. And when you start to look at those places that have very high TB, you can see that a significant proportion is in urban populations, most notably in China and in Indonesia and South Africa. You see very high TB in urban populations. So you realize that focusing on TB as part of urban health and as an instrument to thinking about how to deliver care in communities is really, really important. So I'm going to talk to you about something called the Search, Treat, and Prevent Chakra. This was the method that was used in Western countries starting in the 1950s and 1960s to stop TB. And basically, when people ask, is TB elimination possible? The answer is yes, if you use this tried and tested epidemic control strategy. So let me show you what that strategy is, and you can think about it for a number of diseases. Again, I will talk to you about TB, but you could be thinking in your mind about diabetes, about heart disease, about anything. So the first thing that people did in many countries was to search for people with TB disease and infection. And this was possible in Western countries, starting in the early 20th century, after the X-ray was developed. The X-ray was developed in 1895. And in Edinburgh, in Scotland, they realized that, oh, with an X-ray you can actually see TB very easily. When you use smear microscopy, you only see TB about 50% of the time. But if you do an X-ray, you actually see it about 90% of the time. It's 90% sensitive. So people realized very early on that if you used X-ray, you could screen people for TB, and that's what was done. It became the main diagnostic for screening TB. And in places like the United States and Europe, it was used in the 1950s and 1960s. People would come to these free vans and have their X-ray done. Now, and you'd have large numbers of close contacts. So people would come, and then their contacts would come. If somebody had TB, the people they were living with, the people that they were going to the bar with, the people that they were, hanging out with all the time, they would come and get X-rayed, and they would find hundreds and hundreds of contacts. So this, and interestingly, this not only contributed to finding new cases, but because people were found early, there was less mortality. So remember, this is the 1930s and 40s and 50s when there were no medicines. And even then, if you found people early, you sent them to rest in a sanatorium and you gave them good food, you still got lower mortality. So it was really, really important to be able to find people in the community. And that's why this mobile X-ray vans were incredible. So, you just keep this in your mind, that having the diagnostics in the community and available to people in the communities where they live and work becomes very important. And now we have a lot of new tools. We have mobile X-ray vans. You can see this here. We've got people approaches to computer-assisted reads of X-rays. We have a number of different
somebody with drug resistance, including ones that are almost to point of care.
My echo is
cartridge with a bit of experience.
We have a number of different ways of finding out if people have drug resistance, including a very rapid cartridge-based system to screen people for drug resistance. And then for people who are infected, and I'll talk about this a little bit more, we can tell who's being exposed to TB and doesn't have disease. So unlike the 1910s and 20s and 30s and 40s, we have better technology to be able to do this better. But the idea is you have to have diagnostics in the communities where people are living and working. The second thing is you have to treat the disease correctly. So you need to have the correct medicines that have the least side effects and that can be given to people in the shortest period of time. That's obvious, right? And that's obvious for any disease. You always want to use the best medicine up front. This wasn't the norm for TB. Often countries were told to use things that were not the best, and save the best for later. And this was usually done because people said, oh, it'll be too expensive to give the best therapy up front. It turns out that that's the opposite is true. If you give the best therapy up front, it usually is more value for money because you give people the care that they need quickly, they get better, they don't transmit the disease because it's airborne, and you can cure them. So we have a major problem with that in the world. Because we're not doing the first part, the search part, correctly, we're missing close to 4 million patients worldwide. So I told you there were 10 million TB patients in the world. We're missing 4 million of them. And what happens to them? They continue to spread the disease in their communities. Now, for those of you working with sexually transmitted infections, you know that's the same thing. If you're working with scabies, if you're working with any social disease, it's the same thing. If you don't find the cases and you don't find the contacts and you don't treat the contacts, you actually end up with more transmission of the disease, and then less people are put on treatment. So you have to, the search and the treat are very closely linked. You need to find people, you need to treat them. And in fact, with TB, what's very scary now is that there are drug-resistant strains. Because we're not finding people, those drug-resistant strains are spreading in the air, and they become even harder to treat. And so, in the world, less than 20% of drug-resistant TB patients are cured. That's because we're not doing the search part right. We're not looking for them using x-rays. We're not testing if they have drug resistance, and so we can't get them rapidly on the correct treatment. There's solutions to this. There's shorter course therapies. There's all oral regimens for drug-resistant TB. You can give patients supports, including food. You can give them cash to help them for transportation and other costs. But there's ways to help people get through treatment. But it's very important that we think about the search and the treat very closely linked. Then the last thing is prevent. You know, treating TB infection is an essential part of stopping transmission of the disease. So you really, really have to be thinking about how do we stop TB infection from becoming active disease. So it turns out with TB, and I'm sure all of you know this, but I'll just remind you, if you're exposed, so let's say somebody has TB and they expose the people around them to TB. Some people will get infection. And 1 in 10 people who have infection will go on to have active disease. So if you just treat the active disease and you don't screen the people around, you have a problem. And think about it in terms of sexually transmitted infections. If you just find the index case and you treat them, but you don't find their contacts, that doesn't make any sense, right? Because it's a social disease. TB is exactly the same. If you just treat the index case and you don't think about them in terms of the community of which they're part, you don't stop the transmission of the disease. Now, this was discovered by the US Public Health Service, a professor called George Comstock and colleagues. They were working in Alaska, and interestingly, they started treating patients, they just started treating them for the active disease. And then they started treating active disease in the community, and they realized that they would go in, they would x-ray everyone in the community, and they thought, oh, we found all the patients, and then a few months later, somebody would get TB, and they said, that's impossible. We just screened everyone. And they realized that there was what they considered a latent form of TB. It's actually not very latent. It's actually quite active, and I'll show you that in a second. But they realized that if you didn't give preventive therapy to people who were infected, you still had transmission in households and communities. And what's interesting is when they gave preventive therapy, transmission in households and communities dropped to 0. That was amazing, right? And why is it like this? Well, now we know. People have looked at different forms of disease. When you have active disease, you're releasing a lot of bacteria, but between having no active disease and having active disease, there's these different states called percolator states. And if you don't treat people during those periods, you are going to still have some transmission going on, and you're going to have those people converting to active disease. So 8 to 10% of contacts will get TB during the first 2 years after an exposure to an individual with active disease. So you start to realize, wow, this is really complex. We need to search for people, and we need to search for people who are exposed as well. We need to treat everyone, and we have to treat people who aren't yet sick, but will become sick. What other disease does this sound like to you? I mean, there's a lot of infectious diseases that this sounds like. But when I look at this, I think, wow, this sounds a lot like diabetes. We know that diabetes is clustered in communities and households, right? And we know that some people get the disease, but a lot of people are pre-diabetic. So you need to find them and prevent them from getting the disease. So the same model I'm showing you for TB is exactly what you need for diabetes, for example. Okay, so if you do this, if you do what I've just shown you, what can be achieved? Well, you can have faster progress towards TB elimination. In Alaska, this is what happened. They started their program here, and the TB rates just dropped. So, around the world, if you look at TB rates, I told you they're dropping at 1 or 2% per year. Alaska dropped at 10 to 15% per year. It's amazing. And you say, okay, well, that was Alaska, that's the United States, that's not, it's far up north, it's a different type of community. Well, this is New York City. New York City had an outbreak of TB in the 1980s, late 1980s, early 1990s. It was fueled by people who were homeless, people who had HIV, They were not getting the care that they deserved and needed. And what happened? You had the surge of TB. So what did they do? They did search. They searched actively for patients. They treated everyone with active disease, drug resistant, drug sensitive, and they gave everyone that needed it preventive therapy. And what did you see? The rates just dropped. So now you're going to tell me, well, you know, New York City is rich. Let's look at a different place. Okay, how about this? Here's a Russian prison community, the town of Tomsk in eastern Siberia, where I spent many years working. We did search, treat, and prevent, and we dropped TB rates, with our Russian colleagues, of course, by 55%, more than 10% per year. If you're not convinced and you say, oh, that's Russia, here's another place. Karachi, Pakistan. Karachi, another Asian mega city like Bangkok. They got vans, X-ray vans, just like I showed you, that they had in Karachi, that they had in New York in the 1930s. Except this time they had digital X-rays, and they had computer-assisted reading, something called CAD for TB. And basically, they've screened now, I think, 2.5 or 3 million people. And what they did was really amazing. This is the control area, okay? And this is the intervention area. And something really interesting happened. The control and the intervention area started at the same spot, but when they started looking for patients, they saw a surge. And then they ran out of money, then they continued looking, and then they had this drop. And what's really interesting is that if you look at it, the drop was a 25 to 35% decrease in just the one area of Karachi that they were working, an area that had 2 million people. So even in an Asian megacity with a lot of movement, a lot of migrants, if you do search, treat, and prevent, it works, and you can bring down rates of TB. So what have we learned from all of this, that we can take to thinking a little bit about urban health? Because TB, of course, is important. 10 million people get it. 4,000 people die every day. 3 people die every minute. We want to solve that problem because it's easy. But what can we take from that for the more difficult problems? How can we use TB as the kind of the platform, a health delivery platform for the rest of urban health? Well, we realized with TB that you had to create a system to diagnose and treat people. And you also had to work through the correct unit of political intervention, right? If you try to do this from the top down nationwide, it becomes very hard. And it turns out that it's probably easier to do at the level of the city. Mostly because cities are accountable to their population. There's a mayor and there's a, sorry, I jumped. There's a mayor and there's a, people go to city hall, there's city clinics. Bangkok is pretty amazing. You have many city hospitals and public health clinics in addition to your private system. And so what we realized is that you needed to create something that created islands of elimination. You're never going to get rid of a disease all at once, but you're going to create systems that you can learn from. And so we, with colleagues from the Stop TB Partnership in Geneva, Partners in Health in Boston, Harvard Medical School, a group called IRD, Interactive Research and Development, we started something called the Zero TB Initiative. And it wasn't our initiative. It was bringing together a coalition of cities and other places. And Bangkok was one of them. Dr. Palan, the head of your TB program, who's here today, she was one of the people that joined in this. And basically the idea was, could you use the search, treat, and prevent approach to create an island of elimination by supporting these local coalitions and this comprehensive approach. And right now, a lot of places in the world have joined. I'm happy to say that South Africa has joined, Indonesia, there's a pilot site in India, there's a number of pilots in Pakistan, even Mexico and Germany. Germany decided to join, for the cities where they have a lot of refugees that came in. And so, we realized that a lot of people want to be able to do the search, treat, and prevent for TB. Now, the question that cities always ask is, why am I doing this? Because TB isn't my biggest problem. It kills people, but it's not the biggest problem that cities are facing. And the reason you're doing it is because TB provides the opening to creating a health delivery platform. So let's look at diabetes. I've purposely put this picture here because as you can see, I'm coughing a little bit. And the reason I'm coughing is not because I have COVID, thankfully, but is because as soon as I got out of the plane in Bangkok, the air pollution was really affecting me. And air pollution, of course, causes a lot of health problems. It's estimated to take 2 or 3 or 4 years off of people's lives. And it exacerbates a lot of health issues like heart disease, asthma, diabetes, even tuberculosis. So, when you start to think about it, in places where you have a lot of pollution, amongst other things, you also have a lot of disease that you have to think about. And I realize this is a very complex issue. We won't talk about that today. But, urban places are disease in some cases is easier to get in urban places and is driven by things like pollution. So if you look at something like diabetes, right now, if you look at Thailand and Southeast Asia in general, you see that diabetes is going to grow by 74% over the next 20-25 years. So that's incredible. All of us in the West and in the East faced trouble with COVID, right? We felt that our health systems were overwhelmed. And you can imagine that with something like diabetes, you're going to need to have an incredible amount of health system capacity because people will need kidney replacement therapy, people will need their eyes checked, some people will go blind, unfortunately. You will need to increased pneumonias and other infections, increased amputations. So this is something that you have to get your head around, right? Like you have to say, well, we have to stop, we have to screen people early, we have to make sure that people are on the right medicines, we have to look at other factors that are affecting it, like sugars in the food, diet, air pollution, places to exercise, the multi-sectoral, but there's lots of things to think about. And when you look at it, if you look at urban-rural differences in overweight and obesity, this and again, this is linked to diabetes. This is in 7 African countries, and I realize this is different from Asia, but you see that there's a big urban-rural divide. There's so much more disease in urban areas. Here are data from Tunisia in North Africa, and the dark blue bars on the left are rural areas, and the lighter colored bars are urban areas. And you can see that at every age group, the rates of type 2 diabetes are higher in urban areas than they are in rural areas. So you start to think, okay, how will we build that system? Well, you start thinking about building that system through things like search, treat, and prevent. Now, I couldn't find recent data for Thailand because, in almost every paper I looked at, they weren't dividing it in urban and rural. But if you look at, aside of Thailand, if you look at India, Philippines, Cambodia, you can see that there's a very big difference between urban and rural. I've been told that in Thailand there is a difference, but it's not as significant as what one sees in India or Cambodia. So we have to start thinking, thinking big. We have to be rethinking how we deliver care. In North America, in Europe, in Thailand, we have very big hospital-based systems. And that's really important because people need surgeries and people need cardiac catheterization and people need all the things that a hospital can provide. But we also need to be thinking about how we set up this community-based care delivery system. Now, let me throw some numbers at you. If you're dealing with TB, the rate of disease in the community is 200 per 100,000, right? Maybe in a very high risk community, it may be 1,000 per 100,000, okay? If you're looking at something like diabetes, even if you have 5% diabetes, your rates in the community are 5,000 per 100,000. So when you're thinking about building a system, it obviously is logical to build it for something that has less prevalence and expand it out to something that has more prevalence. And this is, I'm sorry, this thing is on a timer. It seems to be moving without me. In Chennai, where we have a project, we're testing, as we're testing for TB, we're testing for diabetes. And it's really interesting. We're finding very high rates of diabetes in the communities that have TB. And in those same communities, we're finding very high rates of blood pressure. And so through the mechanism we have for screening for TB, we're able to actually get people on diabetes and hypertension care. So really, when we're thinking of taking on tuberculosis in Thailand, and I think you should, because you can move to TB elimination in a country like Thailand. You have the systems, you have the universal health coverage. You should not just be thinking about TB. You should be saying, we are building a platform for community-based delivery for a number of diseases, for HIV, for hepatitis C, for diabetes, for heart disease, for mental illness, maybe even for COVID-19. And I was talking to Dr. Bassam about at lunchtime. She's working on geriatrics. It could even be for elder care in the community. So we need to be thinking beyond just one disease, but use the one disease as a platform. And finally, let me end by saying that today in the world, everyone is talking about pandemic preparedness, right? They're talking about improving biosecurity because of COVID and for the next virus. But again, we have a disease that's killing thousands of people every day. And so we can improve biosecurity, we can improve health delivery by building the system for TB. If you look at it, what does search mean? Finding people who are sick. What is that in the biosecurity language? Having a platform to screen people, limit and contain exposure and transmission in communities. That's what the TB system does. Treat people, so deploy people in the community, treat people in the community. You'll notice that one of the problems we had with COVID around the world was that hospitals were overwhelmed, right? And there's absolutely no need for hospitals to be overwhelmed. You can set up virtual treatment in the community. That's what the TB system has been doing for decades. We have technology to do it even better, right? With smartphones, and you could measure oxygen, you could do all sorts of things. So you have the hospital, and you create a virtual hospital system. So you could actually think about, even from a biosafety perspective, a biosecurity perspective, you could think about how to extend the hospital into the community if there's ever diseases that require that. And then, of course, prevention. I talked to you about prevention in terms of giving preventive therapy. In the case of COVID-19, what very few countries invested in, but should have invested in, was in ventilation and the use of upper room UVC lighting and things like that. So, for diseases that have a preventive component, like plague, like various diseases that you can actually give, ciprofloxacin and like anthrax, etc. Of course, it makes sense from a biosecurity perspective. For TB, we have preventive therapy. For COVID, of course, we didn't really have anything, but prevention is another key part, having a system for prevention of screening contacts, screening relatives, and keeping track of people, not only in terms of themselves, but seeing them as part of a community becomes very, very important. So let me end there. I've gone over time, and I want to take a few minutes for us to have questions. But I want to just end by saying that as we're thinking about this, and as you're thinking about TB in Thailand, my hope is that this last mile of healthcare for TB, which Dr. Palin and others are working on, that hopefully your institution will be working on, thinking about how to do search, treat, and prevent in the community, will help build an infrastructure to deliver primary health care and other forms of health care better in the community and screen people in the community, including children and mothers. I think throughout the world, we've lacked the ability to do this. Certainly in North America, we don't do this very well. And with COVID, we found out our European colleagues in general also don't do it very well. So I think this is an opportunity for Thailand to really create a model that can be used elsewhere. So thank you very much.
Now is the time for Q&A sections. For everyone here, if you have any questions, please feel free to ask us this time. So we have a question for our own as well. We'd like to ask, what are the problems other countries face in the urban area while doing the Zero TB initiative, and how do those countries manage those problems?
Yeah, so I would say the challenge is that, especially with tuberculosis, we're very used to having, doing passive case finding, right? For almost every disease. I'm going to talk to you about TB, but again, we could be having this discussion about diabetes, heart disease, high blood pressure, right? Sexually transmitted diseases. We wait for people to be sick and have symptoms, and then they come in. And of course, as you know, with diabetes, by the time you have symptoms, you're sick, right? Otherwise, you're well, right? It's almost, we know it's not a binary, but for the patient, it behaves as a binary. And the same thing is with TB. You don't know you have TB, you're kind of coughing, you think it's the air, and then bang, you're coughing up blood, right? And you have TB, and by that point, you've infected people at your workplace, you've infected your family, you've infected everybody. So the challenge has been, how do you set up the system? When you're used to passive case finding, it requires a complete mental shift. So in Peru, for example, my wife, Mercedes Becerra, who's a professor of global health and social medicine, also has spent a number of years working in Peru. And in Peru, we've set up a program, a TB program there that our colleagues in Peru and others have been working on, for 25 years. And it's really incredible. In this one community, which is a community that faces a lot of economic problems, rates of TB, the government said the rates of TB were 70 per 100,000. And when we started doing this Zero TB project, we said, well, maybe we can set up X-ray machines, go into this community, and maybe we'll find 100% more. Maybe there's 140 per 100,000. Maybe we'll find double the patients. So we invested in an X-ray machine, and we started a program called Halt TB. And we started working in the community there, and just very initially, when we started just testing the X-ray machine and the computer-assisted artificial intelligence diagnostics, we noticed that we were finding rates as high as 700 per 100,000, 600 per 100,000 in different communities. And then one day, where they had set up the van, the X-ray van outside a mall, and some soldiers, the military recruits were coming. And when they tested them, so these were healthy guys, right? And they tested them, and the rates of TB in that group was 1,000 per 100,000, 1%. And of course, the military people were worried. They said, oh my God, is that so high? And so then they went to the Ministry of Health and said, you need to buy more of these X-ray vans, and you need to screen everybody. And as the screening went on in the community, eventually about 90,000 people were screened, or 80,000 people were screened. The rates turned out not to be 70 per 100,000. The rates turned out to be closer to 600, 550 to 600 per 100,000. And what does that teach you? Well, the problem people had was everyone said, oh, we don't need this. We don't have so much disease. But when you look, it's there. And so in Chennai, I told you we were screening for diabetes. They're finding rates of diabetes of 13%, 15%. They're finding rates of high blood pressure in the community, just family members of TB patients, of 10%, 15%. As you know, hypertension is the silent killer. So I think the biggest challenge is convincing policymakers and really thinking about how do you organize the health system so that you proactively find people. That's number one. Number two is, how do you staff it? Like if I tell you, oh, you need to go screen households, Your logical question, the logical question that anybody here would ask is, well, how many nurses do we need? How many doctors do we need? Can we do it with artificial intelligence? But even if you do it with artificial intelligence and you find people, you have to treat them. You have to buy drugs. If I find, 10 times more patients, I have to give them medicines. So it becomes a supply chain issue. It becomes a logistics issue and a planning issue. And so that's been another challenge. And the way we've overcome that is by recommending with people that they do a phase one. They choose a community, and Dr. Palan has done this in Nakhon Si Thammarat and in a couple of areas with some of you in Bangkok, to say, okay, what does it take to screen people? How much staffing do we need? How much extra drugs, how many extra diagnostics do we have to buy? How many drugs do we have to buy? And then that allows you to plan forward. So there's first the mental change that has to take place, where we say, oh, we're not waiting for people to die before we help them. We're going to help them early so that we can have a healthy population. That's number one. And then number two is thinking, how do we put the system in place to actually do that? And of course, you have to do it in a cost-sensible way, right? And it could be that some communities have a lot of disease, and you create a satellite clinic, and others don't, and you don't do it. So you have to be, constantly be thinking, and again, we're working with people at Harvard about how artificial intelligence can actually think about where to place X-ray vans. If you know how high the rates are in a community, and you know how much infection, can you use that knowledge to place an X-ray van in a community so that you can find the most people? And perhaps you can do the same thing with diabetes, and maybe the same thing with hypertension. Does that answer your question?
Yes, thank you.
Okay. Any other questions?
ทำภาษาไทยก็ได้นะครับ เดี๋ยวช่วยแปลให้
ค่ะมีใครอยากถามยกมือขึ้นได้เลยนะคะเดี๋ยวช่วยแปลให้
Either I was very clear or very unclear.
Okay. On behalf of everyone here today, thank you, Dr. Salmaan, for an enlightening presentation on the right way to apply zero TB elimination to urban health. We appreciate having this mysterious area clarify how we intend to use TB system to be a platform of urban disease and provide active healthcare service for urban population.
We really appreciate and grateful for your presentation. Now, Dr. Chakarud, our faculty dean, would like to give you some tokens of appreciation and thanks. Please welcome Dr. Chakarud.
On behalf of Naominthara University and Faculty of Medicine, Washila Hospital, I wish to express our heartfelt thanks and gratitude to Professor Dr. Salmaan A. Keshavjee for accepting to be our guest speaker and giving the valuable lecture for the participants today. Throughout the entire lecture of Urban Health and Zero TB Initiative, which was highly impressive and inspiring, we have learned about the tools and approaches to control the TB disease, which considered as one of the urban health challenges, since Thailand is still in the World Health Organization list of high TB burden country. Therefore, I believe that the knowledge receiving from Professor Keshavjee will bring a broad perspective to the personnel of the Faculty of Medicine, Washila Hospital, and other involved parties, which can be used in their works to improve urban health implementation in Bangkok and Thailand. I also would like to thank you, the executives of Faculty of Medicine, Washila Hospital, and all participants and organizers who are the key part in making the success of this project. The Urban Health Knowledge Development Project has completed its third consecutive academic activities successfully. I hope that we will have the opportunity to welcome Professor Keshavjee to join our academic event again in the near future. Lastly, please allow me to declare the Urban Health Knowledge Development Project closed by thanking our guest speaker again, and may I invite all of you to give Professor Dr. Salmaan A. Keshavjee a big round of applause. Thank you.
ค่ะลำดับต่อไปจะขอเรียนเชิญอาจารย์ภรินนะคะแพทย์หญิงภรินผู้อำนวยการกองวัณโรคนะคะขึ้นกล่าวค่ะ
Sorry, because I think this topic is very important. Then I told Dr. Baswan, may I can summarize a little bit about the Thai language, our language, yeah. Because I'm working about this area. Because then I will speak พูดไทยแล้วนะ ก็คือว่าอย่างนี้นะคะ คือเป็นคนขอคุณหมอมาสมนว่าขอสรุปภาษาไทยนิดนึงในฐานะของผู้อำนวยการกองวัณโรคหรือว่าในฐานะเขาเรียกว่า national program นะคะจริงๆวัณโรคเป็นโรคสากลนะคะเป็นโรค international ไม่ใช่โรค local นะคะเหมือนไข้เลือดออกเราจะเห็นว่าเราอยู่ในอาเซียนของเราอะไรประมาณนี้นะคะแต่วัณโรคเป็น global emergency ประกาศจากปี 2534 โควิดกับวัณโรคเหมือนกันเลยก่อนที่จะมานี่นะตอนเช้าก็คืออยู่กองทัพไทยนะอยู่กองทัพไทยผู้บัญชาการทหารสูงสุดนั่งทำแผนค้นหาผู้ป่วยวัณโรคในทหารในนู่นนั่นนี่ในปตทพบปตทสนับสนุนเงินมาเพราะวัณโรคเหมือนโควิดเพียงแต่วัณโรคน่ากลัวโควิดด้วยเพราะเป็น airborne disease แบบนี้นะโควิดยังเป็น droplet เนาะแต่โอเคโควิดมันมาอย่างที่ซามันเขาพูดว่าวัณโรคเป็น treatable นะประมาณนี้นะและมีคนเมื่อกี้ key message ที่ดร. ซามันพูดก็คือว่าวัณโรคเป็นโรคเก่าแก่มากแล้วและเป็นตัวอย่างที่ดีว่าถ้าเราควบคุมวัณโรคไม่ได้ดีนะนั่นหมายถึง health system เราล้มเหลวนะคะเพราะฉะนั้นเรื่องนี้เป็นเรื่องที่สำคัญที่สุดเพราะฉะนั้นแล้วในเขตเมืองที่มันอยู่กันหนาแน่นนะทำไมเราเลือกประเด็นของวัณโรคมาพูดเนาะเพราะว่าในเมืองเนี่ยโดยเฉพาะกรุงเทพมหานครเนี่ยมันมี complex มันมีบริบทเยอะมากใน global health ใน urban problem เนี่ยเพราะฉะนั้นตัวอย่างที่ดีที่สุดในการควบคุมเพราะว่ามันเป็น airborne disease แต่ถ้าเป็นdiabetes เป็นเบาหวานเป็น hypertension เนี่ยมันเป็นโรคส่วนบุคคลแต่โรคพวกนี้ก็สำคัญนะแต่ว่ามันจะควบคุมซึ่งแตกต่างกับ infectious control เพราะฉะนั้นถึงยกเรื่องของวัณโรคขึ้นมานะคะว่าถ้าเราทำแบบนี้เราก็เหมือนกับคุมปัญหาโรคในเขตเมืองนะคะก็ขออนุญาตคือโดยสรุปแล้วเนี่ยเขาก็ยกตัวอย่างของวัณโรคขึ้นมาแล้วก็ ใช้3หลักการเนาะ search treat prevent ก็คือว่าค้นยังไงการค้นแต่ละโรคก็มีความแตกต่างกันไปโควิดแล้วก็เห็นไหมคะเราค้นยังไงเนาะประมาณนี้นะที่เราบอกว่าtreat ก็คือเอาเข้าสู่กระบวนการรักษาวันนี้ก็บอกทหารเช่นกันว่าวัณโรคนะก็เหมือนโรคที่มันเดินได้เพราะฉะนั้นผู้ป่วยวัณโรคก็คือการแพร่เชื้อเหมือนโควิดแล้วค่ะนะคะนี่แต่วัณโรคระยะฟักตัวมันนานโควิดมันสั้นเนาะประมาณนี้นะคะแล้วก็ prevent กับ prevent ของวัณโรคเนี่ยสำคัญมากไม่ใช่เรื่อง IC system อย่างเดียวที่มีความสำคัญเรื่องของวัณโรคติดเชื้อ LTPI นะคะแต่เดี๋ยวนี้เราเรียกว่า TPT คนไม่เข้าใจที่ว่า prevention control เนี่ยปรากฏว่า TPT ก็คือการให้ยาป้องกันนะสำหรับคนติดเชื้อในห้องนี้1 ใน 3ติดเชื้อวัณโรคนะ one of the third the population infected with tuberculosis เนี่ยแซมวันเขาก็ชี้ให้ดูที่阿拉斯加ที่ทอมที่ทุกที่นะว่าถ้าเราทำ3 สิ่งนี้นะควบคู่กันไปโดยเฉพาะ prevention ให้ยาป้องกันวัณโรคเราก็จะลดเคสวัณโรคในระยะยาวก็สามารถที่ ending TB ได้หลังจากนั้นเคสมันก็ดรอปนะก็สรุปว่าเขาก็พูดประมาณนี้แหละแล้วว่าเพราะว่าวัณโรคเราจะต้องทำไงก็เปรียบเทียบกับเบาหวานความดันอะไรอย่างเงี้ยนะเพราะว่าตอนนี้คนไม่ยอมกินยาป้องกันกองวัณโรคพยายามเจาะไอกล้าเจาะหาผู้ติดเชื้อวัณโรคทำทุกอย่างแล้วก็บอกให้กินยาป้องกันนะคะเขาไม่ยอมกินเพราะเขายังไม่ป่วยก็คำถามกลับไปว่าเบาหวานกับความดันก็ยังไม่ป่วยงั้นเราให้เส้นเลือดแตกดีไหมแล้วก็ค่อยมารักษาคือเราต้องกินไว้นะคะสรุปแล้วก็คือประมาณนี้ว่าวัณโรค TB เป็นอินดิเคเตอร์เป็นตัวชี้วัดที่ดีในของเขตเมืองบิ๊กซิตี้นะคะเขาถึงไปทำบิ๊กซิตี้ในหลายๆที่รวมทั้งที่เขามาทำที่แบงคอกส่วนหนึ่งเขามาทำเมื่อ3 ปีที่แล้วนะคะแต่ว่าด้วยปัญหาของเรางบประมาณเพราะว่าอย่างที่เขาทำเนี่ยต้องค่อนข้างใช้งบประมาณเยอะก็เห็นไหมรถแวนต้องออกไปกี่คันรถเอ็กซเรย์นู่นนี่ถ้าเอาจริงเอาจังก็จะสามารถที่จะ ending TB ได้ก็เป็นเขาเลยเรียกว่า zero TB initiative นะคะโดยสรุปว่าก็ประมาณนี้ก็กลับขอบคุณค่ะในฐานะก็คือขอคุณหมอบัสวรรณขึ้นมาพูดเพราะว่าเพิ่งมีโอกาสได้เข้างานวชิระแล้วก็เพิ่งได้เข้ามาพูดว่าทุกทีไปแต่ตากสินนะคะเข้ากับสำนักอนามัยอะไรอย่างเงี้ยคุณหมอป่าฤดีก็ให้ความร่วมมืออย่างดีทุกอย่างที่ทำร่วมกันแต่ว่าเราไม่เคยเข้ามาโรงพยาบาลใหญ่ๆแบบนี้เนาะวชิระเนี่ยนะคะประมาณนี้แล้วก็เลยถือโอกาสขอพูดว่าวัณโรคมีความสำคัญอย่างไรนะคะโอเคค่ะขอบพระคุณค่ะขอบคุณค่ะนะก็คือเป็นการสรุปไม่ใช่วันวายเวิร์ดเนาะแต่ซัมมาไรซ์ของเขา
ขอบพระคุณอาจารย์แพทย์หญิงพาลินกมลวัฒน์นะคะผู้อำนวยการสำนักวัณโรคนะคะที่ได้มาสรุปแล้วก็มาอธิบายเพิ่มเติมนะคะที่เราได้ฟังดร.ซาวมานพูดกันไปค่ะก็ขอบคุณทุกท่านนะคะที่ได้มาเข้าฟังกันในวันนี้ค่ะสวัสดีค่ะ